Hi, thanks everyone for coming to our workshop. Carmen and I are excited to talk to you guys about bias and microaggressions. My name's Ripple Shah. I'm a first year attending in psychiatry at Stanford. So I just finished training last year. So whenever I see Dr. Rivera's slides on faculty imposter syndrome, there's a tinge of realness that I feel every single time. So I actually, in case I look familiar to any of you, I actually was once differentiated to the EM path in a prior life. I actually, speaking of stereotypes and generalizations, I talk fast. I have a short attention span, I'm outdoorsy, so everyone in medical school always told me I was going to do EM. I basically never had a chance, and so I spent my fourth year doing 7 sub-Is in EM before realizing, which for the medical students in the room is not the best idea, to be on 7 one-month-long interviews in a row. You'll burn out like I did. And I realized in that time that I actually really liked the psychiatric patients in the ED. I was really gravitated towards the patients that a lot of my peers didn't really want to see, and so I switched into psychiatry. And so I always say that I study bias academically and clinically because now I see the psychological consequences of bias and microaggressions on a daily basis in the sessions in my practice. And in addition to kind of doing this as my career and studying it academically, I've also witnessed it personally. I'm just going to quickly share a personal story about why I've been drawn to this area of research and clinical work, which is I'm from an Indian African family, and so I grew up being part of a biracial family, but over time started to realize that I'm not seen as black in society. I have a twin sister who is seen as black just because of the differences in appearance between us. So we always say we were enrolled in a controlled experiment at birth of how society treats you, and they think you belong to a certain group or not. Everything from in 6th grade when we scored the same on the test, they asked her if she cheated off of me because it was unfathomable for her to do well on a math test, but for me it was apparently in line. Or being followed in stores when I wasn't, when I was the one with the big empty tote bag, but she's the one who gets followed. And so throughout my entire life, I have seen how society can treat us based on our external implicit and explicit biases. So this is why this is something very, very important in the work that I do. So Dr. Earl-Royal already discussed a little bit about bias, so we'll breeze through that in the interest of time. But we're going to talk a little bit more about how to address microaggressions and biases in the workplace and give some tools that we've created at Stanford through the LEAP program that Dr. Powell will talk a little bit more about on how to address these with our peers, our patients, and in a clinical setting. And then we'll also discuss a little bit about how we can frame addressing microaggressions and biases at an institutional level, and an individual level, and an interpersonal level. So we'll start with the intro definitions. Like I said, we'll breeze through a little bit since we've talked a little bit about biases already. We'll do a little bit of an activity and some discussion, and then end with a large group discussion. So the problem is a lot of us clinical providers are not trained in how to handle bias and discrimination. And we are the ones that are in the clinical setting with our trainees, the ones that are supposed to know how to handle these, but we're not trained in it either. And so when these occur, a lot of us don't feel comfortable addressing it. And then students and trainees have often said that it negatively impacts the learning environment to kind of sweep it under the rug and not have a way to process it in the setting that it occurred in. And so this information is based on an older study from the late 90s. We have more data since then, smaller studies, not quite the study that we had here where it studied internal medicine residents in training. So 60% of women reported discrimination, 35% of African American, Hispanic as self-identified on the survey, and Native American medical residents reported being discriminated against during training, and 60% of Middle Eastern medical residents. Like I said, we actually think these numbers are much higher because of more of an awareness of bias and microaggressions today. A lot of work has been done since then for people to understand when they're occurring, but we just don't have a large-scale survey done at the GME level, at an ACGME level. This is a very hot topic right now. This is in popular media constantly, of how society, like I said before, how society views us versus how we see ourselves internally, and what that mismatch can cause in a clinical setting, in the workplace, or in our personal lives. So implicit bias and explicit bias, we've gone over this a little bit, but just quickly, implicit bias is essentially something that's happening on a subconscious or unconscious level, and an explicit bias would be something happening consciously. We'll give examples, and there are some more examples on the handouts that we passed out. And a microaggression would be something that's brief, happens frequently, verbally, environmentally, some sort of environmental trigger where there's either unintentional or intentional consequences that communicate some sort of negative connotation to a person, whether that's racially implied, gender, sexual orientation, any number of things. And so explicit versus implicit. Explicit is more so, I don't want to take this black applicant because black medical students don't make good residents. And an implicit bias would be the black applicants are always at the bottom of the rank list. But we don't know why. We just know that here are all these great applicants and here are these other residents at the bottom. And so implicit would mean we have some bias. It may not be obvious on the outside to the person who's having this bias, but an explicit bias is a very concrete kind of understanding of this is a preferential treatment of this group or not. So we're going to do a small activity now.
Yeah. So just going over kind of both implicit bias and microaggressions, we know they can kind of blend together, but they're also very different in how it's expressed. I like to think of microaggressions as someone having a hot steaming cup of coffee and they accidentally spill it on you and they apologize and they're like, I'm sorry, I didn't mean to do that, but the intent is still, you know, while it's not explicit, the harm is still impactful. So the person who had the coffee spilt on them still feels it. They still feel hurt. So imagine having multiple cups of coffee spilt on you day after day after day. You might end up getting a burn. You might get a scar. So really kind of thinking microaggressions in that way is a really good way to frame it. We have some Post-its at all of the tables. They're color-coded, as well as we have some boards in the back of the room. And what we want you to do is if you have ever kind of experienced a microaggressions, take one of the pink Post-its and maybe write down what that example is. If you've ever witnessed a microaggressions, take the yellow one. And this is just being a bystander as a trainee, as faculty, as staff, kind of what you may hear in the learning environment. And then the orange, if you've ever committed a microaggression, just write down an example, and then we'll give you a couple of moments to take the different Post-its and post it around the room, and then we'll talk about it. All right. Your white handout also has a lot of good examples. If you're trying to scratch your head, a common one that I get is, oh, you're the doctor. I thought you were the nurse, or the RT, or the patient companion. So just think about it, what you've seen, what you've heard. Yes. Yes, no problem. Again, pink, you've experienced it. It happened to you. Someone said this to you, and it's just still that steaming hot cup of coffee on your shoulder. Orange is one that you have committed, and you've said outwardly to someone else. And yellow, you have witnessed. So we just make sure they know the color coding and they start posting them around their own. Oh yeah, we can totally participate, yeah. You're like shivering. Cases at the end, we can look at short. 110.5. If you have a few examples already written down on your Post-its, feel free to stretch a little bit and go to our poster boards in the back and just kind of post those thoughts. Actually, if you want to go to the back room, we may read some of them out. Yeah, and then yeah. Yeah. I always call residents kids. Wrap up here in another minute. And then if you haven't had a chance to, just take a minute to walk around and look at some of the Post-its that have been put up in the room and just read some of the comments. And we have a few questions for the audience. All right, perfect. So hopefully everyone's gotten a chance to look at some of the comments that have been written thus far. We're going to have everyone come back to their seats and open up the discussion at this point, and see if anyone wants to share. Was anyone surprised just by looking at the distribution of where Post-its are on the boards? I see a lot of pink Post-its, so a lot of people have experienced microaggressions. Did anyone have any thoughts on that? Yeah.
I think one of the things too, we commit a lot, but a lot of people don't realize that, and it's hard to admit that.
And just so you know, microaggressions and bias, it's not a one-size-fits-all. We are all guilty of committing them and also also receive them. And it's not just based on race or gender, but also sexual orientation, also your socioeconomic status, also where you may have grown up and your experiences. So realizing that this is a universal kind of issue that happens to all of us. Were there any statements that people may have read on the post-its that you didn't consider to be a microaggression, that you read and said, I didn't know that was one, or didn't seem like it indicated any bias?
I think one that I saw that I don't think a lot of touching someone else's hair is just strange. When you walk up to someone and it's strange if you just walk up to a stranger and try to touch their hair, and just because you want to know. And having experienced it myself a couple of different times and having to redirect myself and not get super angry and just ask the person, like, what are you trying to achieve? Like, what is the question that you have? And then realizing that they just didn't know there's different hair types. And for African American women, our hair is just can be a whole multitude of different things. And so I'm glad to see someone put that up there and realizing that is a microaggression, and it is like something, it's a good teaching moment for that person that does that.
So even the act of invading someone's personal space in that way. So I have had this happen to me multiple times. Actually, recently in a hair salon, a nice little lady decided to touch my hair as it was getting done because she was just so surprised my texture could go from curly to straight and was fascinated. And in that moment, I was like, should I read this little old woman her rights in terms of not invading my space and touching my hair, or should I take this as a teaching moment? But having to deal with that question all the time of what do you do as the recipient of those actions. Any other thoughts? So the last question, were there any comments after reading the Post-its that just didn't sit well with you? That made you feel maybe uncomfortable? Or think of it like this: as physicians who experience this with our patients and families, anything that you've experienced where you weren't in a situation where you could respond in a way, or you felt like your voice couldn't be expressed in that situation? If not, think about it. We'll come back to it. The reason why I bring this up is also for a lot of our trainees. They deal with this regularly, and oftentimes because of the hierarchy that exists in medicine, they don't really have the autonomy or the agency to really speak out or say something. So oftentimes it is really the responsibility of us as faculty, or even as the bystander, or even the more senior person in the room, to really kind of say something and act on the behalf of our trainees and really kind of role model. So that's what we're going to spend that next half of this workshop doing, is just giving some examples of how to start these conversations, because we realize that it can be really hard to do. All right, so why is this so hard? This is just kind of some thoughts we put together as to why this can be really hard to start this conversation about bias and microaggressions. But there's a lot of embarrassment that's surrounded by it. A lot of kind of, your own feeling of like, should I even say something? Should I do something? Does this even apply to me? A lot of uncertainty. What are you going to say? In that moment, what is the right thing to say? How do you not make the trauma or the harm even worse than what it already is? And then also not knowing if you really have any type of therapeutic alliance or collegiality. So let's say it's a trainee that you haven't worked with, and you really don't know them, you don't know their story, and why this is affecting them so much. What if it is a colleague of yours, and yes, you're working together in the same department or the same area, but you really don't quite understand why this is so upsetting. Okay, so that can be really hard to even say something or want to speak up. So we have choices to address or to not address. The thought behind this is that usually when it's more of an adaptive situation, you may not choose to address because you don't want to change the relationship with the offender. So you just kind of adapt to the situation. You just act like, I didn't hear anything. I'm just going to keep going about my day and finish my rounding, finishing my patient. Or you can choose the opposite of generative, where it's a potential to change the relationship with the offender. So the person who makes that comment, if you say something, this is really weird, whether or not you want to say something, it might change that relationship with the person who offended. All right. This is a quote, as we talked about Brene Brown a little bit earlier. You can choose courage or you can choose comfort, but you cannot have both. So how often do you think in medicine that we choose comfort? Just a show of hands. A lot. We do. We're busy. We're task saturated. We have a lot of things that we have to keep going through in our day-to-day just work and in our administrative lives, so it's easy to choose comfort. But I really kind of hope from this session that you decide to choose courage in these situations and really kind of stand up when you can. So in your second part of your handout, there's some sample phrases that we kind of listed there for you, so we're not going to leave you home or going back with nothing there that you can take back with you, but just saying that to yourself. So in a situation where someone may have said, your hair is really interesting, can I touch your hair? And then someone's upset, and that trainee's just like, I just can't deal with this right now. If you just want to be the bystander and say, what I heard, is this what you said? Is that correct? And just reframing it. Another way you can look at this, taking a perspective. So when I noticed X, the impact on me was Y. Okay? And this is someone taking that step if they've received the microaggression, actually speaking out and actually having a way of framing how they would want to say that. Another example is something doesn't feel right to me, but I need time to process it internally before discussing it. I like to address it before the program meeting tomorrow. So this is a way for a trainee who is experiencing the microaggression or bias to just kind of, right now may not be the right time, but I do want to talk about this in an appropriate time. And then also making sure acknowledgement is present. So maybe we can take a second to process this, and I think LA does this really well when we have our discussions. Even though I'm not sure what to say or how to manage this, I want to acknowledge what you're feeling. And I think a lot of times it's really just important to acknowledge that feeling that may arise when this happens, that there was a slight, that there was a hurt, and that you as a bystander, as someone who can be there to start this conversation, that you acknowledge that there may be some hurt feelings. It's really important. Another example, if it seems like the conversation is maybe diverging in an unproductive way. So has anyone been in a situation maybe where they wanted to start this conversation, but it just is getting derailed and you're going off course? Yeah, I see a lot of heads nodding, yes. So in an effort to be mindful of the importance of this discussion, we should consider that there doesn't appear to be enough time to do justice to this conversation, so let's plan to address this at a later time. But then making sure you actually come back and have the conversation at a later time, okay? And then let's say if you want to go back, I've been thinking a lot about what happened and actually stating the time of the incident so people can remember when it happened, how it happened. And I'd really like to take some more time to talk about it, okay? All right. So those are just some sample phrases. Yes, I have a question.
I'm curious how people decide to say something or not. I don't think it's as simple as being verbal or courageous, because there's sort of a range of microaggressions as far as like how bad they are or not, and how egregious they are. And then there's the relationship with the person and the dynamics around that. There's a lot of things that go into it, and it's also exhausting to feel like you have to constantly say something. So I'm just curious how people decide when and what to talk about something or not.
Does anyone have any thoughts?
A lot of that, I think, for me, has to do with my relationship with the person that is being the aggressor. If it's someone that I had not previously met, or it's a new nurse or something who I don't have a particular relationship with, so I don't really know what their background is, I find it more difficult. If it's a person that I've had a couple of shifts with, that I've known for a little bit, and I kind of know their background, and I can kind of
like be like, hey, that wasn't really cool. Why did you say that? Or actually, this person wants to be called this name. I feel much more comfortable, but I find it difficult in situations where I don't know the person or I've just met them, and I'm just like, well, I don't want to be that jerk that keeps correcting this one person, and they don't. And this is their first impression of me is Dr. Walker, the person that likes to correct everyone. So I think it just varies depending on the person.
And I think you bring up a good, well, yeah, over here.
I think it also depends on the space, right? So, like, if you're in the work group and there's nobody else around, it's just the two of you, then that's one thing. Or the person who was maybe experiencing the microaggression is there, like, then you could probably address it. But, like, if it's in the middle of a trauma activation and somebody's like, I had a patient who spoke, I think, Cantonese, and like EMS literally stood at the end of the bed and was like, does anybody speak Asian? And I wanted to say so many things, but that's neither the time nor the place to address that, and nor am I probably the person to address it since I'm not involved with that person at all. And that has to be escalated in a different way. So I think some of it depends on the time and the space and what's going on in that moment.
I think, yeah, yes, yes. No, go.
I guess it doesn't really answer your question, but it asks another one. I'm a trainee, and I feel like I struggle a lot with when to address these microaggressions when patients are, kind of bringing them up. Am I going to change the mind of that 70-year-old man who's saying this thing that I know is overtly racist, and is it worth saying that something in the moment? I struggle with that. Another thing is that, a reason why this topic is so difficult is because when you hear these things, it's such a visceral reaction. And when I feel like when I've experienced them, in the moment, honestly, it's like you're kind of on the brink of tears a lot of times. And I think one of the phrases is it was useful, like, oh, maybe I'll address it later. But at the same time, it's like sometimes I feel like I can't even get words out. And I'm curious from more senior people what kind of mechanisms they've used to really kind of like take a deep breath and when using some of the phrases like, so what I heard is, I feel like that could become very like passive aggressive and especially dealing with patients, how to remain professional but still addressing something that you think is an injustice, when to do that and how to effectively do that. I guess I struggle with that with patients.
So I think you need to practice. Like this is a different kind of elevator speech, right? Like you learn in academics to have your elevator speech, like your 5-minute pitch of yourself to others. But I think this is another area where you have to practice what you want to say so that in that moment you have the composure to take a step back and eloquently articulate what the issue is. So, that's one where I have practiced to say, I really would prefer if you call me Dr. Lal. I'm calling you Mr. Jones, and I would appreciate that you use my proper title. And sometimes patients will hear it, and sometimes they won't. And you maybe won't change anybody's mind, but that shouldn't be how you look at it. You have to look at it kind of from a very personal place to say, I'm going to do the best that I can do right now to make the best of this encounter. And for me, it makes me feel better. It makes me feel a little bit validated that I told the patient how I felt, rather than having this passive-aggressive kind of monologue in my head about, well, they're just a jerk, or they're old, or they're this, right, without putting my own assumptions on them. And it's interesting, sometimes when you say it to patients, like especially, right, are you the nurse? No, I'm not your nurse, I'm your doctor. I'm finding more and more patients that are like, I'm so sorry. I think the culture is shifting. 10 years ago, nobody would have apologized for calling me the nurse. But I do think societal's views and gender norms are changing, so you just have to practice what you want to say. Or well, where are you from? Well, I live here just like you do. I'm from Atlanta. Right? Like you just have to kind of practice it in your own mind so that it doesn't feel so overwhelming to say something.
I think you gave some good examples. We have one more comment in the back, but also take a little step back, because I think a lot of times as faculty, we're easier and have more practice saying these things, but put yourself into that role of a trainee as a medical student, as a first-year resident, as someone who's coming to an institution and maybe isn't familiar to where you grew up in your home. And maybe you're the only one in that residency program who looks like you. Those are all factors that might make the communication that much harder for the trainee to say those things. So I think a lot of times it takes us as faculty to recognize that and be able to step in at times to role model how that communication should go. Because a lot of times trainees aren't seeing that. They're seeing the opposite of like, you know what, we'll just readdress it next time, or, you know, next time if you have a situation like that, say this. But if you can step into that and show that to the trainees, it's very impactful. And I agree with your comment of, you know, there's a spectrum of microaggressions, and we didn't go into all the definitions, but sometimes microaggressions are just overt discrimination or racism, you know. And so I don't want to belabor that point, but just realizing there is a difference in terms of when these actions happen or people say these things, realizing if it's something that is discriminatory, harassment, things like that, then it does call upon our leadership, our institutions to really have a policy in place and a way of addressing it that cuts that kind of behavior right away. We actually have for patients, we tell them this is how we expect patients to behave in our hospital, and this is coming from the pediatric side because it's coming from respect, you know, for the care team, the physicians, the staff, the nurses who are taking care of your child. And if you can't follow along with this contract, then maybe we cannot care for your child in this way. So that's something else, but we can talk more about that. One more comment here.
Just to add on to what Michelle said, and this is for you, when you said, how do I deal with this? I think one of the biggest things that a lot of us don't do is accept that it's okay that we felt that way, right? You take that deep breath and then accept your feelings because they're your feelings. And it may mean that you have to step out of the room before you can go back and finish it. I've had definitely different situations where I'm just like, I can't handle this right now. I'm going to lose it in front of the patient, and that's not appropriate. But I need to deal with my own feelings because it's okay to feel discriminated against. It's okay to be upset. It's okay to be hurt by what's being said to you. And you may not be able to deal with it right then. But I think accepting that and hopefully finding someone, whether they look like you or not, that you can walk up to in the shift and say, I just need to take a deep breath and tell you what I heard because I need to share what I'm feeling and have someone, you know, just hear you say it's okay that I feel this way. And I think that's something that we as both leaders as well as people need to do better about.
Just in the interest of time, we're going to go into our next part, but then we'll have more time for comments. And then just to say, with that piece of it's definitely okay to own your feelings, but it's not okay for this behavior to happen. So realizing that. Yeah. So on the last page, sorry.
Just a moment on unconscious biases. You have that picture there, two white males talking about debriefing biases. What if that was a picture of two black men?
Yes. What about it?
Would it be? I think it looks. One of the things that I often find as an assumption is that people assume that the biggest people with biases are white males, and those of us who are minorities, whether it be by gender or whatever reason, obviously can't be so biased. But turns out it's not true.
Yeah, we all have biases. And actually, this is just a free picture that we were able to put on our slides. So, but thank you. No, actually, when we put this up, we did this last year at one of our forums, and someone brought that up. It was like, it's two white men talking to each other. We're like, oh, you're right. But that being said, it's something that has to be done across all races, all ethnicities, all backgrounds. And I think as, you know, a group that is working on this, I think we need to be able to call it out when we see it. So the next part is a tool that our lead group from last year kind of developed. We're actually in the process of studying this tool with our residency program. But it's an idea of how to provide a safe space and supportive environment to discuss biases, but also this can be used for microaggressions, and also creating a guide to address bias for the learners and hopefully change the culture at your institution where you're able to implement a tool like this. And just so you know, after presenting this workshop at other conferences, more programs are starting to develop communication tools to talk about bias, to talk about microaggressions. So just thinking about this is something you can definitely bring back to your learners. So the tool itself is going around this framework of 5 S's to debrief. The thought was really kind of like in a code situation. After the code happens, you have a framework to actually debrief the code. Who was there? who was present, what was done, what steps were taken, and so trying to use that same framework for dealing with bias and microaggressions and thinking of it as like a hurtful trauma or micro trauma, and how do you want to debrief it. So the first part is going through space. So making sure, as we kind of talked about before, when you're in that code, that may not be the best time to talk about this, and having that, let's step away for a moment and talk about how you're feeling, but making sure you do have a way to create a safe space for the individual who's experiencing the microaggressions or the bias, and also setting an expectation for the conversation and saying, this is what I had heard, can you explain what you felt, and kind of giving that framework. And also, as the listener, being very open and having very active listening as you're going through this process. Also leaving time for self-reflection, really for the person who's experienced the microaggressions or bias, adapting more of a reflective practice of like, how did this make you feel? What are you experiencing? Because there may have been other traumas before they started medicine, before they started medical school, that's being brought up because of that situation that just happened. And also encouraging mindfulness and also providing emotional support, that you're there to support them through this process. Also getting the trainee or the learner to look at the situation objectively, exploring different perspectives. So saying, do you think that patient actually had the intent of harming you with their words? And actually seeing if they can wrap their head around both perspectives, because a lot of times you're focused on how you're experiencing it and how you're feeling it, but not giving a lens to the other side of that experience. And also trying to develop a shared understanding of the situation, so you, as the person who's debriefing this, understands really kind of what has occurred and why there's harm. Also, for solutions, really allowing the learner to explore what would be the next steps, really kind of reframing the situation and encouraging having this difficult conversation. A lot of times, we actually had a study done last year on discriminatory patients and families, and one thing that we got from the trainees is they really wanted to come up with how to resolve the issue themselves, as opposed to being told by the faculty or the attending, this is what you should do. So really letting them go through that exercise of thinking, how would you want to resolve this issue? And last but not least, but most importantly, providing support. So really providing validation, supporting, showing empathy, offering to check in again and talking about this in the future if it feel like it's something that hasn't really been completely resolved in that moment that you've had to speak. And then also providing resources. So this is when you start to get into your leadership, looking at your program director, looking at maybe the chiefs or the chairs, and what other frameworks are in place to help to resolve if this is a recurring issue in your institution. All right, so the last part, and we'll kind of go through this exercise a little bit more briefly so we can wrap up on time. So in the blue sheet, there are some cases. I would just suggest maybe reading one. If you can get to two, that's great. But different cases that go through different clinical scenarios that have some bias and microaggressions, and thinking of strategies of how you would want to handle each situation. Also, if you have one of your own that is more pressing, and I already heard a couple, just discussing that in your group at the table as well, and then we'll come back as a large group and share some of the strategies of how to combat these cases at our own situations. And we'll give about like 5 minutes for this exercise. see a lot of good discussion happening. All right. Just in the interest of time, we'll come back and talk about maybe case 1. Did most people get a chance to read at least case 1 through 2, maybe 3? We'll start with case 1. Case 1, are there any microaggressions or biases present? If so, what were they? That's a bias. Anything else to think of that?
I think there's an assumption by the attending that she's going to be the primary caregiver of this child.
We had one more something.
We kind of said something similar about how having kids somehow makes them less qualified to move up in their field. Something like why that would come up.
My response was, yes, of course. It's perfectly true that children can derail your career. And I would ask presumably the male attending, I would simply be saying, oh, do you have children? Can you give me any advice about how you managed it?
So
Personally, I've always had stay-at-home husbands.
I like, yes, so flipping it maybe on the male counterpart and just asking them if they have children and how they manage it. Yeah. Any other strategies of maybe engaging this conversation? Now, this is a little bit different because this is the female a fellow who's with her male attending, so it's just the two. There's no bystander. But if you were the trainee, any thoughts? So you may not say anything as a matter. What if you were the fellow? So you just highlighted how the level in training can impact maybe what phrasing or what comment you might say. Just in the interest of time, case 2, did anyone get to case 2? This is a third-year medical student who's working with an attending in a primary care clinic that serves mostly Spanish-speaking families in an underserved area. The attending overhears the student making comments to other students how he doesn't understand why these people just can't learn English or why these patients can't just be compliant with their medications. So the perpetrator is the student, and you're their attending. And this is in clinic, they're overseeing this. Any thoughts? I think we can agree that there's microaggressions and biases here. I saw a hand.
One of the biggest things about a situation like this, especially with the issues with student mistreatment, is to make sure you pull the student aside in a private area and have a conversation. And don't have, if you are going to have a conversation in front of everybody, it needs to be an overview addressed to everybody saying, you know what? The United States doesn't have a national language, and because of that, we are obligated to offer patients care in their primary language as best we can. If you choose, and just putting it that way. And that's what we're going to do here at this. So you can address it generally to the whole group, but if you're going to address it specifically to that particular student, which definitely needs to happen, it has to be in a private area where it can't be overheard. And in a polite and politically correct way.
So I like that it's maybe 2 different conversations. So one, globally, if this is being said in a clinic setting an example of we don't tolerate that. So as the attending, you're setting the tone for that encounter. But then maybe pulling the trainee aside and having another conversation about, okay, what's going on here? Why are we saying this? And maybe there's some misunderstanding. Maybe he's never been in a community that was mostly Spanish speaking. He's frustrated. Or there's other things that you can explore, but making sure you pull them aside and having that conversation too. I saw one more hand raised, and we'll go to case 3.
Well, I was just saying, one of the statements you were saying, pull the student aside. I know some of the issues I've had in just pulling the student aside by themselves. So I've actually gone through the medical the medical school and gotten the honor, and we sit down with the student, because then, you know, I'm labeled. Then it's interesting how the biases all are entangled. So, you know, I'm labeled as, oh God, you can't say this kind of stuff in front of me. And then, as the black faculty, you know, I'm this abusive, horrible woman that I pulled him aside and said these things to him, and now he's crying, and I'm biased on him now because I pulled. So it just becomes a nightmare, which is what I found. So I try to start a lot of our engagements to remind the students why we're here, and, you know, let's have this professional environment. And I try to open it up before we start, but I was just saying that has actually caused some issues with me because I've pulled the student aside.
I completely agree.
Yeah.
You have to make sure you don't do it in front of other students, whether you get somebody to be your witness so that that's perfect. But as long as they don't feel, I mean, I had the same issue where they're like, you're a horrible person because you told me things in front of other people. I'm like, I'm sorry, in the we have that conversation, I just have to correct what you're saying because you're an innovation. Like,
All right, we'll go into the last part. And then we have one more comment here, and then we'll just do the last, 2 more guesses.
I think there's something powerful in self-reflection, and so I might not necessarily directly address it in like a you were wrong kind of manner, but like just turn and say, that is such an interesting comment, please do tell me more. And usually that's enough to shut them up and reflect on what they just said, and that was probably not a good move. And it shuts down the entire conversation, and we can address that privately later, but they immediately get the recognition that what they just did was wrong.
I would just say that I really like the wheel in your model, and I wanted to add a piece under the solutions part, in that it is going to be a fact of our careers that this is going to happen. It's not just in medicine. So what I would like to encourage us to do as attendings and as residents and students is to really have a tool belt ready so that you're not surprised by any of this when it happens, and actively collect tools. So we heard all kinds of wonderful examples in here. I would say this, I would say that. I would actually compile these and make a list of, well, when this happens, I'm going to do this, so that you're not surprised by it and you're one up on it. So I would add that to your solutions piece as an active component.
No, thank you. And we're learning so much as we continue to present a lot of this information, and thank you so much for participating, because we're learning as much from the audience as we're getting a chance to learn about these topics ourselves and teach them out. As we kind of highlighted before, there are kind of many parts to the solution, but looking at the individual piece and learning how you can kind of regulate and interrupt the microaggressions, and also using more microaffirmations, which is more positive comments, to counteract those instances. Interpersonal is looking at opportunities for faculty development. So really, how do you bring this back to the institution? Maybe there's an opportunity to do some faculty training on communication, resident level training, and having workshops around this. And also institutionally, what we also did was a learning climate survey. So it's one thing to say it's happening, but of course in medicine we need data to prove anything. So we actually did a survey looking at this within our own institution and in our department to track this. So actually, whatever interventions we have, we can see that we're seeing an improvement and we're actually counteracting the culture. So next steps, we'll, of course, at the end of the day, ask you to write down some of your own thoughts, but thank you so much. And I'm going to hand this off to Alai, yes, for the last part. Yes, one more question, yeah.
So, I'm trying to figure out how to do. I have my. Oh. Go ahead. This is great, right? Raising awareness. You've given us some steps. You spent, I don't know, half hour, 45 minutes. You need days, weeks, years to really get into this. It's really important, the whole practice piece. I just wanted to share with everybody a resource. I don't know how to do it. I have it right here on my laptop. There's a guy named Daryl Ling Su. All right, so he's at Teachers College at Columbia University. He actually visited our institution. We had him come and talk. He wrote a book called Race Talk. And his area of real expertise and interest is in dealing with microaggressions. So he has a publication that he shared with us. I have it here, and it's just a way. It's titled Disarming Racial Microaggressions, Micro-Intervention Strategies for Targets, White Allies, and Bystanders. So it's a publication, it's a resource that's out there where you can read about it. You know, what do you do? So a lot of the things you said here, that's in his paper. It's just in more detail. What do you do if you're experiencing it? What if you do if you're a bystander or an ally? So I don't know what to do.
I love it. If you give me that link later on, I'll give you my card. I'll put it in the web. So we have an online notes that we've been writing all this time, so that each of you will actually have a copy of the talk, so you can take it home with you. That's part of the toolkits that we're creating.
Yeah.
Thank you, Dr.
And
Lopez.
just so you know, we completely understand this is not a 30-minute worth discussion. We actually created this into a 9-month curriculum at our institution to really explore and flesh this out more. But what we're learning is that our trainees really are experiencing the weight of this and actually have a lot of the tools and the solutions to try to resolve some of these issues. But it's getting our faculty on board with also being the role models to continue this forward. So thank you for that comment.
Right.
If you feel like you have an ally attending or someone else, I think it will make your life a lot easier.
Yeah.
You know, I'll share one thing, like I just remember being a third-year medical student in Fort Pierce, Florida, which is a very small town, about an hour north of West Palm Beach. And I was in the family medicine rotation. It was myself, an African-American female, a very out black African-American male, and a Indian male. We were all doing the same family medicine rotation together. We all volunteered at this free clinic. And we go to see this patient and taking a history. He's there for like preventative medicine. We go to examine the man. He takes his shirt off, and he has a giant swastika from here to here, and then on his back, a giant Confederate flag. And he didn't say anything, but I could just see like the steam coming out of his pores of these three minorities taking care of him. And our attending cis white female, just nothing was said after the encounter. It bothered me for many, many days. Like, man, I don't know if she really has my back, because this obviously these three people were clearly affected by this patient.
Yeah.
He didn't say anything, but he let us do our exam and everything. But it was just I felt like that was a great moment for her to create a rapport with us about how do you feel, how did this affect you? Because it did. For a couple of days after that, I was like, I don't want to see any patients.
Thank you for sharing that.
This clinic is going to be like this. I don't know.
Yeah. That's a great story, and I love how we're able to create such a psychological safety here that we're engaged, we're sharing each of our stories.